We're going to start, if that's okay. I thought better start actually on time since we're doing something about standardisation and needs improvement method. Okay, so welcome very much to Report Out. This is the first time I've presented Report Out, so I'm delighted about that. So we've only got one team that are reporting out today, but it's a good team. It's an outstanding team, which is our critical care team. And they're reporting out, as it says on the board, for the RPIW1 ICU bed availability, as Jimmy keeps pointing out to you. It's about bed availability. Okay, so it's a 90-day report out. And Jane, I understand you're the person reporting out, so please, if you'd like to come up. Oh,
Helen's going to add on for me. How do I move the...
You click and just decide that.
Okay. And I'm pointing at there on the screen.
Either or.
Okay. So this was the value stream for adult cardiac services, and it was Simon Worthington as our exec sponsor, looking at ICU bed availability. Helen Robotham was our sponsor, and hello, my name is Jane Atkins. I'm the process owner. Project forms got very, very complicated and very full, so all the information is there, but I shall whiz over that. As you can see from the target progress report, majority of things are in green. In fact, it's all in green. Some of the percentage increases have been very small for the 90-day report out. That's mainly because a lot of what we've done was already embedded, and there was not a significant change for this 90 days. A lot of it happened quite early on in some of these things, so the percentage change from the start was actually quite small. Our newspaper and list of things that we individually looked at, the consistency, a big thing was just to improve patient flow through from the start of their journey going to theatre, having their surgery, and then coming out of theatre, the journey through intensive care. There wasn't really a lot of consistent approach to stepping down on intensive care, and we managed to relaunch our wake and wean protocol. This really has helped the junior staff with their confidence and progressing the patient quite quickly, and that's now embedded and doing really well. There was an inconsistent availability of the HOBS beds up on Ward 16, but thanks to Helen and her tri-team and the team, we've had HOBS beds consistently staffed now since the November RPIW that we did. We've had no problems with patients flowing out of ICU into HOBS. We're still working on a progress review plan for patients, to sort of a multidisciplinary progress report, so that we can actually keep it very neat and have a documented progress report, which is helping the nursing staff when we've got sort of anaesthetists and surgeons wanting different things and saying different things. It's nice to have the information in the same place. Communication regarding the availability of the beds was very good between ourselves in ICU and theatres, but the patient themselves up on the ward wasn't getting to hear. We've developed a flow chart which we've continued to evolve on instances that have happened since November, and we're now, I think, on about version 7. And actually the end result is that the patient is getting informed, and they get a sort of a yes, no, or don't know, but at least they are informed, which is helping them. Other things, there was a delayed start in theatres on quite a few mornings, and because the theatre porters weren't booked until everybody was ready. Now the theatres are pre-booking porters, so the patient is actually always ready in theatre to start on time, and that's again embedded and working really well. Nurse education and confidence in a lot of the nurses up on Ward 16 and in HOBS had completed all the competencies to look after the step-down patients, but the confidence wasn't there because the consistency of the patients going up to HOBS wasn't there. The nurses lacked confidence, so the nursing staff from 16 have now all rotated through ICU, and one of the ICU nurses has gone up there for a prolonged period of time to help gain confidence. I think that was the big thing. They had the competencies signed off, but it was the confidence that they lacked, but now they're all doing great. There's still a little bit of work we're working with the medical staff a little bit more to try and get some standardisation to the ward rounds, so that the ward rounds are happening promptly up on 16, so that we know which patients can step out of the HOBS beds, so we know which beds we have available to step patients out of intensive care into. And it's work in progress, but we're getting there, and we're definitely better than we were. This is the flowchart we're sort of saying about the communication. It has evolved, looking quite busy now. Probably not very clear actually on there, but we've evolved the flowchart so that the patient flow team communicate with each other, with the ward, with theatres, and say predominantly the patients, so they actually get to know what we know, which is there's definitely a bed. There isn't a bed at the moment, but we're working on it, or there definitely isn't a bed. So at least they do get the information, as opposed to lying there just waiting and waiting, because it is a long wait. They don't leave the ward until lunchtime, but they're obviously prepared and ready from very early in the morning. Moving on to the good news story bits. This is a graph just showing the outcome of the cardiac surgery patients that we achieved, and then those that were cancelled. The blue bar is the patients that had their cardiac surgery, and the red bar is all patients that were cancelled on day. And as you can see, back in September, before we started looking at things, basically we didn't do very many patients, and actually half of them were cancelled, and that's cancelled on day. October, we did more patients, but we cancelled an awful lot more as well, so again, still not very good news. In November, when we did the RPIW week, as you can see, we had a brilliant week. We did loads of patients. There were still some on-day cancellations, but we were improving. December, obviously it was Christmas. We weren't the expectation of taking as many patients. We didn't do as many cases, obviously, with the bank holidays. But we still had, cancellations were still a lot less than half as they had been. January, we did a lot of cases. There still were a significant amount of cancellations. But obviously the hospital was at the time in silver quite a lot of the time, so flow was quite poor. And February, I think it's just, to us, it's shown this continued improvement. We've done a lot of cases, and cancellations, on-day cancellations, are definitely not anywhere like they were. These are the reasons for on-day cancellations. Again, not brilliantly clear. The blue bar, the furthest in each month to the left as you look at it, is intensive care capacity being the problem for the on-day cancellations. And as you can see in October, horrendous. It was all ICU's fault. In November, we had no cancellations due to critical care capacity. December, we had 2. January, as I was saying, the hospital was in silver, so it was quite poor. Our flow was quite poor, discharging patients out. So yes, we did have a number of cancellations in January. But I was very surprised, and thanks to Alex for doing the slides for me, when he got the slides back to me this week, that actually, I didn't know what the results were, but we only actually had 2 cancellations due to critical care in February, which we're really pleased about. And the very good news story is the length. This graph shows the length of stay for cardiac surgery patients in cardiac ICU. And basically the graph showing you that the first bar, again the furthest to the left as you look at it, the blue bar, is patients that leave ICU after within the first 24 hours. The next bar is 2 to 3 days. And as you can see, sort of up to November, the majority of patients went out on 2 to 3 days, the red bar, reddy-orange bar. Most patients went out on 2 to 3 days, with very few going out, discharging to Hobbs on day 1. In December, that things were improving. Hobbs was obviously gaining confidence, but there were still more patients going out on day 2 as opposed to day 1, same in January. And again, extremely pleased to see that for the first time we've had actually more patients going out, a lot more patients going out on day 1 than on day 2 and 3. I think because we've got the confidence in the Hobbs beds, we've got the staff on intensive care and on Hobbs able to move the patients through the process. I think that is... So say the number of patients leaving ICU in less than 2 days has significantly improved, and for the first time more patients were discharged from ICU on day 1. And actually the really good news story is all those patients have gone out on day 1, but actually definitely since November, but actually for a good few months, since November when we did the RPIW patients, there's been no patients have returned to intensive care from the ward. So even though we have significantly improved the number of patients to go out on day 1 and day 2, these patients are obviously ready to go out, and they are fit to go out because no patients have come back. I did think just because with the nature of everything, the patients we've got, 1 or 2 would have come back, but actually nobody has returned back to intensive care. And Hobbs have been consistently staffed throughout, which is what I think has really helped and there's confidence in the delivery of that Hobbs care to patients. A couple of things, the blue ones, sort of people have said up on the ward to me that the patients said up on the ward that they felt informed throughout the day, and it really helped, especially for visitors who are also sitting there just waiting to see whether there will be a bed available for them down in intensive care. And then patients that are on intensive care were really pleased to move out quite early because they felt it's a noisy and a scary place. I've often found it myself. But actually, they felt that once they knew they could go back to the ward, they've actually felt like they were making real progress, and that they were feeling a lot better. It helped them psychologically. Pink bits are what some of the nurses have said to us over the last few weeks and months. The Ward 16 staff really enjoyed rotating down to ICU, and it helped them gain the confidence when they went back up to Hobbs patients, because they sort of saw a lot of the things they were asked to deal with, and they actually really helped them gain the confidence. And the nursing staff down on ICU felt really satisfied that they were here to place as many cases as possible and not to cancel anyone, and that was what they were now doing, and that was really good. And I just now feel that it no longer feels like the norm that patients will be cancelled, that one or two will be cancelled. It actually feels like, you know, if there's even a hint that somebody might be cancelled, everybody works together. And again, we're working across 4 CSUs at times to try and actually get these patients done. And I think it's now what people are trying to do, as opposed to just accepting that unfortunately we'll have to cancel. Actually, everybody works together and works really well, and it's not the norm to cancel. And that's me. And I'd just like to, before we do questions,
just want to finish. I'm Helen Robotham, and I was a sponsor for this RPIW. And I think you'll agree with me in that Jane and her team have made amazing improvements to the cardiac surgical patient experience. I mean, it's just phenomenal to see some of this at the end. Not only have we made, the patients have seen that real difference, and all the staff working within the cardiac surgical pathway now feel that they are making a difference, and that's why everybody is striving to keep these improvements going. I mean, the last slide that showed that the majority of patients in February went out in less than 24 hours, I think we need to admit have amazed us, haven't it? Because at the start of this process, we never thought we'd be able to achieve that, and it's fantastic, and it's all due to Jane and her team and their hard work, and the wider team as well, that have got engaged with this process, and now they're starting to see the difference. They really want it to continue. So we do feel at this point it is the right time to close down the RPIW, but that doesn't mean to say that Jane and I are going to stop. We will continue to monitor the progress of the improvement, and we're going to feed it back through the cardiac surgical governance meetings, which occur monthly, and we'll have the cardiac surgical team there as a target audience, so that we can ensure that this process continues, and we continue embedding these improvements in practice, so that more and more patients will benefit from this. And I think they've just done an amazing amount of work.
Thank you very much.
Thank you.
Hang on.
No questions.
Have we got questions for Jane and Helen? I know I have, so... Oh, yes, please.
Yeah, just wanted to ask, you said you'd reduced the number of readmissions to the cardiac ICU. What were the reasons for the readmissions? Did you identify what they were to start with?
Helen and I did look into the readmissions prior to the RPIW, and I think we had 2 or 3, and I think we sort of put it down to a couple of them were lack of confidence, as in as soon as the patient maybe looked like they were not going in the right direction, the knee-jerk reaction was to move them straight back to ICU, when sometimes they didn't necessarily need to come back. They could have been managed in the environment they were in, but the confidence wasn't there from the medical or the nursing staff. So I think with gaining that confidence, the patients can be managed better in that environment, again without moving them, which was a better experience for the patient as well. And then there was one, I think when we looked at the 3 we looked at, there was one that had deteriorated quite significantly respiratory wise and did need to come back, and that was the right move for them to make. And I had expected, especially doing this, collecting this data over the winter period, that we would have had 1 or 2 of those type of patients that it was just, you know, that they did just need to come back to intensive care, but actually we haven't had.
And on the ward, we've prevented some of the level 1 patients going back to critical care, because we've managed to step them up into Hobbs and then managed to make them safe in the Hobbs, and then they've gone back to the ward rather than back to intensive care. But again, as Jane said, a lot of it is a confidence that the anaesthetists, surgeons, nurses now have the confidence to care for those patients on the ward.
So going forward, it's about maintaining that confidence.
Yes, absolutely.
If that's the reason they're coming back. That sounds like something you can sustain.
Yes, we certainly can. Rotating the staff through intensive care, having the intensive care nurse back up on the ward as well, it's really helped.
Great.
Mike?
Well done.
I think it's fantastic, in terms of, this is an area we've struggled with for a long time, isn't it? In terms
Yes, yeah.
of, we all thought it should work.
Yeah.
There shouldn't be a reason why we were having the cancellation volumes that we were having in cardiac, and yet whenever anybody was trying to look at it, we just couldn't get it right somehow. Different pieces of the jigsaw didn't quite work together. And I just wondered, what was it about the RPIW process specifically that helped you overcome those problems that we've been going at for 10 years probably or more, haven't we?
I think one of the big things is that it's across 4 CSUs, and even though everybody works collaboratively together, you still work in your CSU and your meetings are all within your CSU. I think with the RPIW, you pulled people from different CSUs to sit in the room at the same time. So I think that definitely helped, because I think it's helped sort of forge relationships. I mean, the fact that even though the ward and HOBs are obviously in cardiorespiratory and intensive care is in adult critical care, we wouldn't normally be sort of rotating nurses out of CSU, but we sort of thought that's what needs to happen. So, Helen and I had asked previously if this could happen, and it sort of really wasn't sort of looked on as a yes, it could, because it was 2 different CSUs, but we did it this time. And it has worked. And again, it's not just about the competence. The nurses had the competence. It was the confidence of actually being in that area and dealing with arterial lines and central lines with lots of patients, so that when they're up on the HOBs bay with 1 or 2, that they felt confident. And I think that then gave the surgeons and the anaesthetists the confidence that to discharge the patients into that environment. And one of the nurses is going up there for a few months.
And it was a multi-professional approach as well, and I think that certainly helped.
Yeah.
There was an anaesthetist, wasn't there, a surgeon, nurses, there were lots of different people that contributed to the RPIW, and that really helped.
And I just wonder whether there's real, because this, for cardiac now, it could be neuro, it could be AMS and some of the issues we have on this site. I just wonder whether there's 2 or 3 key things that made the difference.
We certainly think the HOBs beds made the difference, didn't we? And we used to have level 2 beds, as you know, within cardiac surgery, and they went when all the level 2 and level 3 beds went into critical care. And I think the anaesthetists and surgeons had lost the confidence that the ward was able to care for these patients that needed a higher level of care, and that's what we've managed to get back. And I think the HOBs has given that, and I think that's made a difference.
Yeah, but I think also for me, from actually doing it in the RPIW bit, there was a lot of assumptions that I'd made, but actually, I assumed, because we know that the first cases, in my head, the first cases went at 7:30, but when I went and stood in theatres at 7:15 for a week, the patients weren't arriving till 10 to 8 o'clock, because porters weren't booked until everybody was ready. So actually, it was my assumption was that it started at 7:30, because that's when we said yes, they go. But actually, having stood in theatres, and actually the patients weren't arriving till 10 to 8 o'clock, because porters weren't booked until everybody was ready at 20 to 8, 4 to 8. So by pre-booking porters, even as minor as that, at 7:30, theatres were starting 45 minutes earlier, or able to start 45 minutes earlier than they were. So the first cases were finishing earlier, so there wasn't a knock-on effect of, there still is times when they overrun, but not as many. So I think it was, and not just that, again, my assumption was that we had a wake and wean policy, that everybody was adhering to it out on ICU, but again, when we went out and looked, the confidence in the nursing staff wasn't there, because the medical staff weren't, there was no sort of documented what they could and couldn't do. So it was again about sort of my assumptions of what should be happening, and actually standing there and seeing what was happening and what wasn't, and what we could improve.
So I think that's a perfect example of where there is no substitute for direct observation and walking together. I think that's a perfect example of that. Are there any other questions? I've got a question, So I'm thinking about next winter, and when we enter into next winter, because we saw some dramatic improvement from December and January and February, which was looking great, but there were still patients that were cancelled, so that was still a patient experience opportunity, shall we say, in that area. And I'm just wondering whether or not there is more that we could do preemptively around this, and identifying before the patients come in.
The next work stream, which is another reason for us closing down this one now, obviously we'll continue with this work, but then there are the slide that I showed with the patients that have been accepted and the patients that have been cancelled. They were all cancellations, not just critical care. They're all cancellations. So I think the critical care availability. So they were all cancellations. So yes, the critical care ones have come down, but there are other areas that again now can be looked at. I think the assumption prior to doing this work as well was that any on-day cancellations, it was critical care. It was just straight down to it's critical care. And I think obviously you can see October, it's our problem. It really was our problem. But actually as we've moved forward, the cancellations are still happening, but critical care, there will always, I'm sure, be certain days when it's out of our control that we will have to cancel patients due to critical care. But there are other areas now that maybe need to look at the work that's being done to take the assumption away that it's critical care, that actually there are other areas that could help to improve the on-day cancellations as well.
I do still wonder whether or not for using forecasting or something like that in terms of length of stay, patients having the bed base, whether or not there is something there around.
I think there is something at looking at when we know when we're in that really difficult position, looking at what we've got planned to do the next day, and possibly thinking, well, we're not going to be able to do 6 cases as I listed tomorrow. And sometimes we do know that, so that we need to make that decision then. And what we're looking at in the next RPIW, we're going to look at the pre-assessment process. And what we're hoping is to have a pool of patients that are pre-assessed and ready to go and are happy to come in at short notice. So we might possibly only list 4 cases instead of 6 and have 2 in reserve and explain that to them. Are you happy for us to ring you in the morning if we're going to be able to do more work
so
than
you're
the first time?
describing real close daily management of your
absolutely.
process.
And that's what will hopefully come out in the next RPIW, that we're really excited about, that we can make these improvements in a different aspect of the journey.
I mean, I think what you've done here is absolutely phenomenal. It really, I mean, you've really made a huge impact really on.
And I think this is going to have a real positive effect of getting more people to engage in the process, because they've seen that it does work. Because the people in this room know that cardiac surgery has struggled for years and years to make these improvements, and we've actually managed to do it. Yes, we can still get better, we're not there, but we have made a significant improvement.
May I have another round of applause? Okay, everybody, that actually brings to an end our report out for this week. I think I was so excited about the fact that Helen and Jane were going to come up and talk to us. I forgot to introduce myself. So apologies, those colleagues that don't know me, my name is Claire Smith and I'm the Interim Chief Operating Officer. So very nice to see you. Thank you very much.
Thank you.
Bye.
We need to talk about those others. I've not seen it up there.
I know, that's why I want